Good evening, everyone. I am Dr. Priyanka Bharti from NMCH Patna. Today, I am going to present a case of Tenon's patch graft in perforated corneal ulcer. I have no financial interest. A 25-year-old female patient coming from Patna city presented in our OPD with chief complaint of pain, diminution of vision, redness, and photophobia for 2 months. History of present illness, no history of trauma with nail, using multiple medication including steroid, painful diminution of vision, gradually no onset, rapid progression associated with redness and photophobia. No any significant masked medical and surgical history, no history of any addiction. Ocular examination, uncorrected visual acuity was hand movement and IOP was digitally low in the left eye. Anterior segment examination in the left eye, perforated corneal ulcer of size 4 into 5 mm with corneal edema and infiltrate of size 5 into 6.5 mm was present in the left eye. Anterior chamber is shallow, iris is plugging to the wound. Pupil obscure, lenticular opacity is present in the left eye, while right eye is within the normal limit. Diagnosis, provisional diagnosis, perforated corneal ulcer with iris plugging. Investigation, routine examination is within the normal limit. Corneal scraping was taken on table in OT and sent for microbiological examination. AIOCMTC done to monitor the wound healing. Treatment, the patient was planned for Tenon's patch graft with conjunctival advancement under LA and started on topical antibiotic, antifungal, cycloplegic, antiglaucoma, oral, antifungal and anti-inflammatory drugs. Surgical management, Tenon's patch was harvested from the inferior quadrant of the bulbar conjunctiva and plugged into the perforation and secured with 10-0 suture. Conjunctival advancement was done and also secured with 10-0 sutures. Post-op advice, the patient was advised to have oral antibiotic, anti-inflammatory and oral antifungal drug and topical antibiotic drop and ointment, topical antifungal, cycloplegic, antiglaucoma drug. On post-op day 1, visual acuity is 5 count, graft in place, suture intact, corneal edema with DM fold present, AC form. Microbiology report, smear broken fungal hyphae seen, culture no growth is seen. Patient is advised to continue same treatment. On post-op week 1, visual acuity is finger count FC 3 meter, graft in place, corneal edema with DM folds. Post of week 2, visual acuity improves to FC 2 meter, graft in place, corneal edema decreases and frequency of eye drop are reduced per day. Post of month at 1 month, visual acuity is 6/60, graft in place, graft well taken up, 3 sutures are removed. At post of 3 months, visual acuity improves to 6/60, graft well taken up, cornea is clear, and the patient is continued antibiotic drop and ointment and carboxymethyl cellulose. And patient is reviewed 2 weekly and it is still under follow-up. AIOCMTC done at 2 months so that Tenon's patch graft get incorporated into the corneal stroma and the conjunctiva get intermingled with the corneal epithelium. This is the timeline showing follow-up of serial number of photographs which is showing the cornea is getting clear day by day and the vision is improving. Discussion, Tenon's patch grafting of a paracentral perforation gives good refractive outcome, minimizing astigmatism, acceptable rate of endothelial loss, addition of conjunctival flap, rapid replacement of lost stromal tissue, complete filling of the perforation, vascular remodeling within the conjunctival flap, correlate with the course of wound healing, formation of conjunctival feeder vessel within 4 weeks, spontaneous regression by 4 months. Patient young age increase the likelihood of rapid vascularization and healing. Combining Tenon's patch grafting with a conjunctival flap resulted in much faster healing as compared to Tenon's patch graft alone. Conclusion, it is an effective, accessible and affordable method, restore tectonic integrity, preserving clarity of the visual axis, reducing surgically induced astigmatism, reducing the need for keratoplasty, beneficial where there is limited access to eye banking, add healing with favorable post-operative refractive outcome. Thank you.
So thank you, Priyanka. That was a nicely managed case. Sir, any questions you want to ask?
No. It's using Tenon's is an approved way of managing a tectonic support, giving a tectonic support for perforations. So I think what she did is right.
Okay. Ma'am, any experience of using Tenon grafts in infected cases? Because personally, I've also done Tenon graft, but most of them were either sterile melts or peripheral corneal perforations, either traumatic or mostly sterile melt patients. So not in infective cases have I tried myself Tenon patch.
Yeah, in acute infections, of course, it's not a great idea if you have a perforation, but we have used it. So one of our fellows looking at, we have about all the cases that we have done, maybe about 12, 14 patients in which in acute infections we had done a patch, probably because of
Lack of tissues.
yeah, not lack of tissue, probably because we thought we could
Some
do
smaller
it,
perforation.
yeah, it's a smaller perforation,
Okay.
and we can handle that with a Tenon's patch graft rather
Okay.
than multi-layered AMG and it wouldn't be amenable to glue.
Okay.
And it seemed to be doing well.
Because
Yeah,
as such,
yes.
suturing the graft is a little different from suturing a corneal tissue.
Yes.
So suturing in the presence of infiltrate and surrounding
Yes.
sloughing
So
is...
most of the time with the TPG, we don't suture, or we suture with onlays. So we
Onlays,
don't place
okay.
it into the corneal stroma. So the onlay has to be beyond the infiltrates. You can't use it for if there's a lot of infectious material, where most of the infectious material infiltrate is gone, and you
Yes.
have most of thinning and a perforation, and it's still infection though. So those would be an appropriate indication for TPG, not an active infection where you have a large exudate. By no means can you, or large infiltrate. I don't think this is the appropriate strategy. So her case was appropriate in that
Yes.
case.
Thank you.